Welcome in, everyone. Hi. Hope everyone's doing well. I want to thank you for joining us. I'm going to give it just a couple of seconds, as usual, to let everyone get in and get settled. As we do, you're welcome to use the chat to let us know what state you're joining us from and say hi. You may need to toggle there's a button on the chat that says who you're sending the message to. It may default to panelists and hosts, but you are welcome to change that to everyone so that everybody can participate. So I am joining you from Ohio today. Okay, looks like our numbers have evened out a little bit, so we'll get started. So my name is Amber Johnstone, and I'm with the ALS Association. I want to thank you for joining us for another installment of our Empowering Your ALS Journey webinar series. The goal of this series is to empower you to live fully and with purpose, regardless of where you are on your ALS journey. The title of today's webinar is Supporting Your Breathing in ALS, What to Expect and Available Options. A few things to know before we begin. Rest assured that you're muted and not on camera, so you can relax and enjoy the presentation. We'll be using both the chat and the Q&A feature today to allow you to participate in the discussion. You can take a moment now to locate those buttons at the bottom of the screen. And if you haven't yet, go ahead and use the chat feature to say hi and let us know what state you're joining us from. There will be time at the end of this webinar to answer questions. I want to kind of preface things today, since it is a very specific topic, that I will not be answering questions in the chat, but I will be gathering them for Dr. Warren to answer at the end of today's discussion. You can use the Q&A button to submit your questions, and those can be submitted at any time during the webinar. We do have a short survey that we ask that you complete after the webinar. You shouldn't need to do anything once the webinar ends. It'll pop up on its own. And the survey helps us to know your thoughts on not only this presentation, but topics that you'd like us to consider in the future. Lastly, this webinar is being recorded and should be available on our Empowering Your ALS Journey webinar page within about a week. This is also where you can view recordings of our previous webinars. And with that, I'd like to introduce our speaker, Dr. Melissa Warren, who is an assistant professor of medicine at Vanderbilt University Medical Center, serving as the neuromuscular pulmonologist within the multidisciplinary ALS clinic. She completed her internal medicine residency in pulmonary and critical care fellowship at Vanderbilt prior to joining the faculty in 2017. In addition to caring for individuals living with ALS, Dr. Warren is actively involved in the broader ALS community. She serves on the ALS Association Southeast Territory Mission Committee, participates in regional efforts to standardize ALS care practices, and is a member of the NEALS Respiratory Care and Ventilation Committee. She's deeply committed to advancing respiratory care in ALS and to supporting patients and families throughout education and advocacy. Dr. Warren, thank you so much for joining us today, and I'm going to hand it over to you.
Perfect. Well, thank you so much for having me and for that introduction. As Amber mentioned, I'm going to chat with you today about all things related to respiratory care, kind of in this journey with ALS. I've kind of timed this talk to be about 45 minutes in length, and so happy to answer any questions you may have at the end. Oh, let's see. There we go. I have no financial disclosures for this talk. So as you all know, ALS is a very person-specific disease process that people develop symptoms at different sites in their body, and they have different progression of disease over time. And my goal here today is really kind of to create a roadmap and to give you the knowledge that you can advocate for the care of yourselves and the care of your loved ones. So I want to start out this talk by talking about kind of normal respiratory function and how we typically breathe in a normal fashion and how ALS affects your muscles over time and some of the signs and symptoms that you can monitor for at home so that you know when and what to talk to your care providers about. I then want to transition from those subjective symptoms that you might find at home and tell you about some of the objective data that we can look at in clinic to help us better understand and test your respiratory muscle strength. We'll then transition talking about how we combine both those subjective symptoms that you have, the objective data that we have in clinic, and how we look towards support devices and treatment options for your respiratory health. And those can be things like BiPAP or other forms of non-invasive ventilation, cough assist devices for airway clearance, or suction devices. And then I'll end the talk by discussing some more advanced modes of support, including things like feeding tubes and breathing tubes, and really trying to discuss the importance of establishing a good relationship with your ALS care team so that we can really identify things that are important to you and what your overall goals are. So when we talk about breathing, this is probably the most technical slide that I have, but when we talk about breathing, a lot of people think about the lung tissue itself, which is a really important way to start, right? And I tell people that your lung tissue, think about it like a vine of grapes. So you want these big open airways, right? These big vines that branch off into these smaller airways as you get deeper into your lungs. And at the bottom of those airways, the bottom of those vines, you have big grapes. And you want big plump grapes and big open air sacs to be able to appropriately diffuse oxygen and carbon dioxide from your lung into your bloodstream. And those grapes in your air sacs are able to stay open with the help of your muscles and help your muscles opening up those air sacs. And it's really a coordination between your upper airway muscles, your respiratory muscles in your chest, and even some abdominal muscles in your belly. And so if you look over here at the diagram on the left, you'll see that there are a lot of structures and a lot of muscles really up here in your upper airway. And your upper airway is helpful in coordinating both good airway clearance and good cough, and also ensuring that when food or secretions are in the mouth, they are adequately swallowed and they go in the back portion of your throat where your esophagus is, and they don't go in the front portion where your windpipe is. And so having good coordination and good strong muscles in your upper airway are important. Then, when you take a big deep breath, that's a combination of multiple small muscles in your chest and really your diaphragm, which is your main muscle of inspiration. With normal breathing, your diaphragm contracts down, you take a big deep breath in, and then exhalation is really a passive process. Depending on your level of exertion, people might start using accessory muscles to allow them to take bigger, deeper breaths. And then when you cough, you start to engage your abdominal muscles to allow you to to have kind of a more forceful airway clearance. What we know happens is, oh, excuse me. Sorry about that. What we know happens is that at some point, and again, this is very person dependent in this process, ALS begins to weaken some of those muscles in our chest, our upper airway, and our abdomen. And that can all impact breathing and airway clearance in different ways. This is weakness that typically occurs really gradually over time. Rather than someone noticing a difference between one day to the next, this might be something that you can kind of zoom out and see how things might have changed for you over time. And initially at home, these symptoms present at night. Okay, so when I see people in clinic, I always ask them how they're sleeping. I ask them if they feel like they're having restful sleep, if they feel like they're tossing and turning or not having good quality sleep. This can lead to daytime symptoms like daytime fatigue, feeling like you want to take a nap most days. Sometimes people describe a feeling of kind of having a brain fog, or you can have headaches, specifically morning headaches. And those can all be signs and symptoms at home that maybe you're not getting big enough, deep enough breaths at night, and maybe there are ways that we can support you to make you feel better overall. Over time, we know that these symptoms can progress, and often those symptoms that are only present at night, people will start noticing during the day. One way that you might start to notice symptoms changing at home is feeling as if when you're in different positions, your breathing is a little bit different. So when you're sitting upright, your diaphragm is assisted by gravity. We know that your abdominal contents, any abdominal fat, any abdominal organs are kind of hanging down as well and assisted by gravity. And as we start to recline, you work against gravity and your abdominal structures kind of move up to where your diaphragm has to work against them. So everyone has a little bit of a change in their breathing pattern when they start to recline back. But with muscle weakness, we know that maybe certain positions will be less comfortable. So you might notice that being flat on your back in bed is not something that's comfortable. And doing things like sleeping on a couple of pillows or sleeping reclined might be more comfortable. You might find that things that you used to do that maybe didn't cause any breathing problems, you start to notice some breathing changes with different levels of exertion. And this can lead to different breathing patterns at home. Normally, what happens is that your body regulates certain volumes of breath and certain numbers of breath every minute so that you can regulate your carbon dioxide. If you're not taking bigger breaths as you normally do, your body will start taking more shallow breaths, but more frequent breaths to continue to kind of transfer that carbon dioxide from your lungs into your bloodstream. And so the mechanics of how you breathe start to change, and you might recognize that, or your loved ones might recognize that. You might start engaging some of those accessory muscle groups that typically were not engaged before. And so people might recognize that when they breathe, they kind of breathe a little bit more from maybe their neck or their shoulders, or they can see kind of retractions in their chest. And then something that sometimes people don't recognize until maybe they're asked is this can change your ability to have good airway clearance. And so I ask people in clinic, do you feel like you have a good cough? And I often am told, I don't think I have a problem with cough because I don't cough. And although that's a valid statement, I really challenge you to kind of think about if you do have to cough, if you did have issues with airway clearance, do you think that you have good strength with which you can clear your secretions? Because if not, there are ways that we can help augment that. The other thing that I ask people to keep in mind is sometimes a poor cough or poor airway clearance really manifests as kind of this upper airway throat clearing. So some people end up saying, well, I think my cough is fine, but I find that I'm clearing my throat quite a bit. I always feel like I have just kind of something right here in the back of my throat. And that can be a sign that maybe there's some difficulty with that upper airway muscle coordination. And maybe there's something that we can do to kind of help clear those secretions that rest in the back of your throat. So we talked about some of the subjective symptoms that you have at home, and now let's transition into some of the objective ways that we can monitor this in clinic. Now, this slide is really a reference slide and has a lot of information, and I'm going to spend the next two slides specifically talking about pulmonary function tests. But I wanted you to have some data points to go back because different clinics do a few different things. So pulmonary function testing is by far and away the main way that we address and measure your muscle strength in the clinic. These can be done in the clinic themselves with portable devices. They can be done with a respiratory therapist in the respiratory lab. And some clinics have these where people can go home with a portable device to be able to measure their spirometry at home. These are always done upright, but some centers and some specific occasions, we might do these flat so that we can better understand the involvement of the diaphragm, the involvement of the diaphragm and any potential weakness. And this is something that is measured at least every 3 to 6 months for most people. Now, there are other ways that we can measure your carbon dioxide levels, and that's by an arterial blood gas. An arterial blood gas is a needle stick in your wrist. It measures blood from an artery in the wrist, and it can tell us what your carbon dioxide levels are. This can be helpful to understand timing of initiation of certain support devices or even titration of those devices, but often is not necessary depending on what your lung function tests look like. These are not always readily available in all clinics, and they can be a painful procedure. So for me personally, this is something that I only pursue in people if I feel that it'll make a meaningful change in something that we're going to do. I bring up this next point, this transcutaneous carbon dioxide monitoring, because there are some centers that are starting to do this real-time testing in clinic. And I do think over time, we're going to start seeing more of this. Transcutaneous carbon dioxide monitoring is real-time monitoring in the clinic where there's a machine and a non-invasive probe, typically something that goes on your ear, that can measure real-time carbon dioxide levels. They can allow people to initiate support devices such as BiPAP in clinic and then titrate the pressures to make sure that we're optimizing carbon dioxide levels appropriately. The difficult thing is the cost. They can be very expensive machines and they require a lot of maintenance. So although not incredibly mainstreamed right now, I do think that we might start seeing these over time. And some of you may have access to a clinic who is currently doing this. And then I want to end by talking about sleep studies and really impress two different points about this. The first is that you do not have to have a sleep study to qualify for support devices like BiPAP or nocturnal ventilation at home. These can certainly be used as an adjunct in testing, and there are some centers that have readily accessible and readily available sleep studies where they can use them to get people qualified for nocturnal support. They can use them to titrate that support. But oftentimes it can be hard to get a sleep study. There can be a delay in the length of time in which you can get this set up. And I want to make sure that you all know that there are other ways in which we can talk about support devices at home. So let's talk a little bit more about these lung function tests. So this picture is the setup that we use here at Vanderbilt. This picture was sent to me by my respiratory therapist, Chris. And we really followed two main numbers. The first one that we do is your forced vital capacity, or your FVC. So when people talk about their lung function number, this is often the number that they're referring to. And what we do is we measure, we have you take a big deep breath all the way in, and then you forcefully blow that air out. And we measure the volume of air you can blow out from a full inspiration. And that actual number that you're able to do is compared to the predicted number that we expect someone of your height, age, and sex to be able to do. And that comes up with a percentage. So a normal percentage would be 100%. And then we tell you where you fall based off of your actual numbers. Two things are really important here. One, especially the first time that you get this test done, this is very much a snapshot. And so understandably in my clinic, when I do these numbers, people say, well, what should I expect for next time, right? What are these numbers going to look like in the future? And I really explain to people that these are a snapshot, right? I tell everyone in clinic, I need more data points to create kind of a flip book so I can see that trajectory over time. It's also really important to recognize that these tests can be difficult to do, okay? To be able to coordinate your muscles, coordinate that deep breath in, that blowing out. And especially if people have bulbar weakness or muscle weakness in their mouth, it can be hard to get a really good seal on this mouthpiece over here. And so it's important to kind of talk to your ALS care team and recognize what this number means for you and if this was a good data point for you. And just as a reference, we know that early initiation of BiPAP or other forms of nocturnal support can improve both quality of life, and there is a survival benefit. So there's data that talks about initiating these respiratory support devices when your FVC is less than or equal to 50%, or newer guidelines have come out talking about initiating respiratory support devices if your FVC is less than 80% with symptoms of elevated carbon dioxide. And those are those things like daytime headaches, daytime fatigue, poor sleep. The second type of pulmonary function test that we get is something called your maximum inspiratory pressure. And that's really a measurement of your inspiratory muscle strength. And we know that your diaphragm is that main muscle of inspiration. So it's really a surrogate marker for how strong your diaphragm is. This is more sensitive than the FVC and can detect muscle weakness earlier than the FVC can. It is also incredibly dependent on how good of a seal you can get on that mouthpiece, so may be a little bit less reliable in those who have some bulbar weakness. A normal MIP is greater than -60 centimeters of water, and we recommend initiation of BiPAP or other forms of nocturnal support devices if your MIP declines less than -60. So we talked about some of those subjective symptoms. We talked about that objective data that we can get into clinic. And I want to spend a good chunk of time right now talking about how support devices that we have for you. And I really want to impress upon you that these support devices are really true treatment options. And we have good data that says that these can really help with quality of life. And there is a survival benefit with use. And so I really advocate for these things in my clinic. So when we talk about respiratory support devices, we talk about non-invasive positive pressure ventilation, and that really breaks that down into two categories. The first is BiPAP, which I'm going to go into more detail with, and the second is non-invasive ventilation. And we're going to talk about the comparison between those two. Then we're going to transition to secretion management, both mucus secretions in the chest and saliva management, and talk about specific devices such as the mechanical insufflation-exsufflation device, which you may hear about. It's commonly referred to as the cough assist, and then suction devices and other ways that we can help manage saliva in the outpatient setting. So here's a picture that shows you BiPAP options on the left and the non-invasive ventilator options on the right. I want to go through and first just talk about the BiPAPs. So BiPAP is universally the first thing that people get prescribed during this respiratory journey. The goal is to use this at night or anytime with sleeping, so at night and with naps. These are fairly small, they're lightweight, they are about 2.5 to 7 pounds. And they allow for different pressures to allow you to take bigger, deeper breaths. This is a rent to own machine. So this is something that you have a copay with through your insurance company. You rent them for 13 months and then you own this device. There are a variety of different masks that I'm going to show you that can go with all of these machines. But the one downside to the BiPAP machine is that there is no internal battery. There are occasionally external batteries that you can get, excuse me, but they can be expensive and they're not covered by insurance. So this is less of a portable option and something that's really only used for nocturnal use. If you transition over to the NIV, the non-invasive ventilators on the right side of your screen, you can see that they're bigger machines. They have larger screens. And I'll discuss this a little bit more later, but they really are meant for kind of more advanced modes of ventilation. And they have some different settings on them that allow you to be a little bit more portable. One of the main things to recognize with this is that the non-invasive ventilators have internal batteries and often have an external battery. So these are much more portable and they allow people to put these on their wheelchair or to leave their house. These can be used, at night and all throughout the day. And so this offers a lot more support. The downside to this is that this is a rent forever option. So this isn't a rent to own option like the BiPAP is. This is something that you have a long-term copay for. So overall, it is more expensive. Now, when I bring up these devices in clinic, understandably, people often say they're not sure if they can use these types of devices at night because they're really worried about feeling like they're claustrophobic, which is a very understandable feeling. I wanted to show you guys a few different types of masks so you can see the different options that we have. I think most of the time people have either had an experience either in the hospital or they have seen different types of masks, and they very often think of this mask here on the left of the screen, which is that full face mask. It's covering the bridge of the nose. You have these two straps around your face. There's a tube in front of you, and it's just a little bit cumbersome. There are people who can do well with this at home, and they find that this is adequate support. But when I'm prescribing BiPAP as an outpatient, I often try to do this middle mask here, this nasal pillow. So you can see here in this picture, this just kind of cups below the nose. Your mouth is free, which allows for improved communication. The bridge of your nose is free if you wear glasses. And then the tubing comes out the top of your head. So instead of feeling like you have something kind of in front of you, this sort of swivels on the top of your head and kind of gives you a little bit more freedom. And then there's a hybrid mask that's over here on the right-hand side. And this is still called a full face mask. But again, the benefit is it goes underneath your nose. So the bridge of your nose is free. The tubing comes out the top of your head. And then something to note, this one is the white clips down here. Those are magnetic clips. So especially if people are having issues with kind of fine motor dexterity and it's harder to get those straps on, there are multiple different types of masks that have magnetic clips on them, which can be much easier to kind of put on and then take off later. These pictures also show different types of masks that you have at home. Again, the full face mask, here a nasal mask in the middle, and then nasal pillows on the right-hand side. But these pictures are really supposed to depict these red and blue cloths. What these are chin straps. And so it's kind of a little support hammock for your mouth. Often at night, what happens are people's jaw begins to relax. They can get a lot of leak. It can cause some difficulty with tolerance of the mask or the device. And so this can be a way to maybe help tolerate the mask or diminish that leak. Not everyone can tolerate or not everyone likes a chin strap, but it's something that we often offer people in case they feel that it would be beneficial to them. So every time I talk about BiPAP, people want to know the difference between CPAP, which is a very good question. Most people are very familiar with CPAPs because they might previously have been on one for obstructive sleep apnea or have known someone. And the main difference is that CPAP is a continuous positive airway pressure machine. It has one continuous pressure, and that one pressure has the goal to stent open the airways that are obstructed in obstructed sleep apnea. BiPAP has two pressures. So there's an inspiratory pressure that when you initiate a breath or when your provider has timed a certain number of breaths in the device, it triggers a pressure that allows you to take a bigger, deeper, fuller breath. We kind of talked about those airways at the beginning of this talk and about how those grapes can get sort of squished down with muscle weakness. And so this helps push in a pressure, helps reinflate those air sacs, and it allows for better gas exchange. And then there's a second, much lower pressure that helps to decrease the resistance on exhalation. And really, the goal of using the BiPAP at night is to decrease the effort your muscles require to breathe. People understandably become very concerned that starting a device like this makes you dependent on the device. And it's very much not that you'll become dependent on this. This is a true tool and a true support and treatment option for people. We know that there's good data that says that there's a lot of benefits with BiPAP and other forms of non-invasive ventilation. Specifically, people have improved quality of life. They have better sleep quality. They have increased energy. They've reduced brain fog and decreased headaches. And I have many people, especially after we're able to really figure out those perfect settings. I have many people who say they're not sure how they slept without it before, and they feel so much better using it. And so the goal is that we're able to kind of work together to find sort of those Goldilocks settings and those right masks to help you feel well supported at home. We talked about that gas exchange being beneficial with the pressures allowing those air sacs to open up more. And then we know from data that not only do you have improved quality of life, there is a survival benefit with both early initiation and longer use of the device overnight. So these can be incredibly helpful. I summarized here's just a reference slide for people who really want to know numbers, all the different ways that you can qualify for a BiPAP machine or a nocturnal, a non-invasive ventilator at home. And these can be done with lung function tests, which is how we mainly do it. It's that number below 50%, that muscle strength number. It's that inspiratory muscle strength number less than -60. And you can do things like sleep studies or arterial blood gases that specifically look at either your oxygen concentration or your carbon dioxide numbers. Now, once you get BiPAP, I really kind of talk through what you need as follow-up so people know what to sort of expect after the clinic visit. And sometimes people say, well, let me get the device and I'll use it if I need it. It's really important that once you get the device, you really give it a try because insurance requires you to use that device greater than 4 hours a day in a 24-hour period for 70% of the month. And these are cumulative hours, not consecutive hours. So there are some people who, if we're really good on our side and we pick the right pressures and we pick the right settings, some people can tolerate a BiPAP at night kind of right from the beginning. Understandably, though, you go to sleep at night, you're trying to get comfortable, you're trying to put on this, foreign mask, kind of have this different machine try to breathe for you, and it's a weird setup. And so I tell people it's okay if you want to try to use it during the day. Sit in your chair, turn on a show, get distracted, and really try to understand what this machine can do for you and how it can help you breathe. It can also help you understand if you feel like the mask is weird or if there are certain settings that we could help change. And I have a slide here in a little bit that talks about ways that we can troubleshoot your device and ways that you can communicate with your care team to talk about how we can make this much better. Okay. And then it requires follow-up with your provider in 30 to 90 days after initiation. So people often say, well, why would you go from a BiPAP to a non-invasive ventilator? And why would you not just start out with a non-invasive ventilator to begin with? We always start out with BiPAP machines because we know that one, they are going to offer adequate support for most people right out the gate. They are cheaper, and as I mentioned, they are a rent-to-own option. And so it is nice if people have rented this option and then they have the device to own down the road. There are reasons why we would talk about transitioning to a non-invasive ventilator, and that is typically for more advanced support. Okay, so the non-invasive ventilators have internal batteries, typically around 6 to 8 hours, and that really allows for improved portability and improved mobility. I have people who I care for in clinic who are able to put their non-invasive ventilator on their wheelchair. They might wear their nasal pillows much of the day, and they go on various outings. They feel like they have some independence back, and they are able to do the things that are important for them. They are able to achieve that quality of life that they're looking for. There are other modes of ventilation that we'll talk about with mouthpiece ventilation. And then should you decide that a tracheostomy is within your goals of care, this is a machine that can go from non-invasive ventilation with the mask to more invasive modes of ventilation through the trach. This is an example of that mouthpiece ventilation. So this is completely controlled by the person using the device. We as the provider, we set a volume or a pressure. And there are two forms of mouthpieces that you can do. So there's this mouthpiece at the top, and then there's a straw mechanism on this one on the bottom. You can have this type of tubing either hooked up to a rolling cart in your home. You can have this hooked up to your wheelchair. And this can be something that can either be mounted or you can pick up yourself. And should you choose to, maybe you need more support than just overnight, but you don't need support to where it's worthwhile to put your mask on during the day. This is something that you at your leisure can say, I would like to take a big deep breath of air, and you can use this device. Now we set a volume and a pressure. And again, we want that to be a big volume and a big pressure. This isn't like the passive breathing that you get with your BiPAP or your non-invasive vent overnight. This is meant to really be kind of a recruitment maneuver. So it really is a big deep breath. And I have a lot of people who find it beneficial if they're doing things like talking on the phone or having company over, or if they've been active and they just need a minute to rest and take one or two big deep breaths. This is something that can be kind of used as little as you want, maybe once or twice a day. And I have people who might use it a few times an hour. So talk to your care team if you feel like this might be something that is that kind of fits you have stuff at night, you feel like you might need stuff during the day, but you don't feel like you really need to sit on a mask during the day. So none of this is going to work if this device isn't set right for you, right? And I have a lot of people who say, well, I don't know really how to articulate what's going on, right? I don't know how to say it's not working for me. And so I've tried to kind of give some questions here that you can think about and maybe relay back to your care team. So the number one thing is mask fit. Masks are like shoes, okay? If no one style fits everyone, no one size fits everyone. And so if your mask isn't right, then most other things aren't going to be right either. So I really encourage you to figure out, kind of work with your care team to figure out a mask that fits best for you. And then after that, we kind of say that it's almost like we become eye doctors in a way. Is it better one or better two? And so we'll say things like, is your breath too big or too small, too fast or too slow, too early or too late? And all of those things, if you can kind of try to figure out, oh, that's what it is. I want to breathe longer and the machine is stopping. Or I want that breath to come faster, but it's giving it to me too slow. Those are all things that we can change. Um, we have about 6 different settings or so that we can manipulate on the devices, sometimes more depending on what device you have. And so these are all things that can be really helpful. I also want to comment that don't underestimate the power of humidity. So all of these devices have either a built-in an internal humidity system or an external humidifier that you can get. And humidity is something that really changes with the seasons. So right now in Tennessee, where I am, well, the weather's kind of crazy, right? It was like icy and then it was 70, now it's cold again. But it gets really dry here in the winter. And so I've been telling everyone, hey, make sure that you look at your humidity settings and feel free to increase that, right? You might feel like, man, at night my mouth is really, really dry. My secretions are getting thicker. It's harder for me to cough stuff up. And a little bit of humidity at night can really help with that. Vice versa, in the summertime, it gets very humid here, and so you might have to start dialing down that humidity. But those are some changes that kind of can change with different seasons and different weather patterns, but can really help with compliance and feeling well supported with your device. So now let's switch over from that respiratory support and talk more about secretion management, both saliva, but then mucus in the chest. And we'll start with the mucus part of secretion management. I kind of talked about at the beginning of this talk that it's really a coordination between this upper airway muscle coordination, good inspiratory strength, and then a strong exhalation that allows you to really mobilize secretions and ensure that we're decreasing the risk of aspiration and infections like pneumonia. But as muscle weakness occurs, that leads to decreased coordination, decreased lung volumes, and then ineffective cough. And we know all of those things together increase the risk of aspiration and airway clearance. And so there are both manual techniques that your provider might teach you how to do, things like abdominal thrusts that can help with cough and airway clearance, but also cough assist devices that can help with this. So here's a couple of examples of cough assists that we have. The picture on the left and in the middle, those are some of the older versions of the Philips T70 cough assists. And this device here on the right, the BiWays, that is one of the newer versions that we're starting to see more commonly. And you'll notice that there's both a mask version of an interface over here on the left, and then a mouthpiece version on in the middle. And we really encourage the mask form of interface. It allows you to get a better seal. It's not as dependent on having good bulbar muscle strength and good an ability to kind of hold on to that mouthpiece. And here's the goal. It's going to provide a strong positive pressure, so a big deep breath in, followed by a very rapid negative pressure that tries to really kind of pull those secretions out. And we know that it mimics a strong cough, and it helps to really adequately clear secretions as muscles weaken over time. And we know that this can reduce respiratory infections. This is something that may be recommended based off of certain lung function tests that you can get done in clinic called a peak cough flow, which we didn't talk about earlier. Not all centers do peak cough flows, but they can also just be recommended clinically. For me, we know that data shows that the BiPAP and non-invasive ventilation, those are important for quality of life improvement and have survival improvements. We also know that when you combine cough assist measures with this, that also leads to improved quality of life and again, survival benefits. So I'm really a proponent of getting people early cough assist. I think that if there's a question about if you're having issues with airway clearance, if you're having issues with frequent throat clearing, I think it's beneficial to get these devices because this isn't something that comes overnight, right? And we know that if you ever do get an upper respiratory tract infection, cough strength weakens acutely. And so it's nice to have something there. I really counsel people to use this every day, twice a day. Wake up in the morning, do 5 to 10 coughs, 5 to 10 repetitions, do that again at night. Then you kind of clear up the secretions that have accumulated over the course of the night. You clear the secretions that have accumulated over the course of the day. And that can also help people tolerate their non-invasive ventilators a little bit more. It can also help with that amount of throat clearing, right? So some people feel like they have improved tolerance while they're eating. They feel like they have less kind of that tickle in their throat throughout the day, and that can be helpful. Something that I really counsel people on is the importance of recognizing that just because mucus doesn't come up, that doesn't mean it's not working. So if I cough right now, in theory, I should not get mucus that comes up necessarily. And that's true for a cough assist. You know, oftentimes, if it's doing its job, right, if it's blowing air in and sucking it out, you're still kind of mobilizing some of those microsecretions. You're opening up those air sacs, and you're kind of just making sure things are staying clean, if you will. Certainly, you could start bringing some stuff up, or if you're sick, or if you feel that there's stuff in your chest, it might require some augmentation of those pressures. And it's important to talk about these pressures with your ALS care team. So I gave some typical settings, kind of this positive 30, negative 30. There's typically a range kind of in this 20 to 40 area. There are times when people like less strong of an inhale and a more forceful exhale to kind of really pull secretions up. That's something that you can help talk to your team about. Some people, especially if you have upper airway bulbar symptoms, sometimes that people can benefit from having much lower pressure so that we're not having upper airway closure with it. And so again, it's really helpful to kind of talk to your provider about what you're feeling. I have used one of these devices and they should not be painful and they should not be uncomfortable, but they're odd. It's a really weird thing, right? To have a machine cough for you. But again, if you can kind of get in that rhythm, this can be something that can really improve your quality of life and ideally reduces infections over time. So now let's transition to talking about saliva management. So In ALS, it's not that you are creating more saliva, it's that the saliva may become more difficult to manage. Not everyone has issues with saliva. Sometimes people have issues with more dry mouth, but for those who have issues with saliva, there's a variety of different options that we have to help clear up that extra saliva, or that, not the extra, but the difficult to manage saliva. So one is a suction device, and that's very similar to something that you see at a dentist office. Okay, so you can have a portable suction device. It has a suction container on the back, and it comes with a wand that you can put around your mouth and help to clear that saliva. Suction devices can also be helpful in after you use your cough assist. If mucus does come up and if it's hard to spit out or hard to swallow, you can have a suction device to help kind of clear those secretions as well. But if you're having difficulty managing your saliva, it's really helpful if we can try different medications to see if we can manage that. And there's a few medications down here: glycopyrrolate, which is also called Robenal, atropine drops, which go under your tongue, scopolamine patches, which go behind your ear, and then amitriptyline. And these can be used in different doses and frequencies, and some of these can be combined together to see if we can reduce that saliva production. Oftentimes, medications can be enough, but if not, we can talk about doing Botox injections to your salivary glands, and that can help dry up saliva and usually lasts for about 2 to 3 months. And then there's some data that talks about radiation to the salivary glands or removal of the salivary glands, but those are much less commonly used. So we talked about the subjective symptoms that you can feel at home, the objective data that we can get in clinic, and some of these support devices. And I want to spend the last few minutes talking about kind of some more advanced modes of support. And that really kind of gets into this conversation of goals of care. And this is an area in my practice that I feel very passionate about. And when I meet people in clinic, just oftentimes by chatting with them, the goal is really to figure out who you are as a person and what is important to you. It's important that I understand what your goals are and what quality of life looks like to you, because everyone has a different version of that. And whatever I can understand from you, that can help me kind of guide all of the options that we have, right? And to figure out if is this something that would benefit you in your personal journey. And so we know that as breathing changes over time and as muscle weakness changes over time, more advanced modes of support, things like help with eating with feeding tubes, commonly called PEG tubes, or breathing tubes called tracheostomies, those might be discussed. And I know that these are hard conversations to have. And I really encourage you to think about it yourself and talk about it with your loved ones, and then talk about it with your care team so that we can find the best way to help. Outside of being an ALS provider, I also work in the ICU. And I think it's very important that we avoid sort of crisis-based decision making. We know that decisions made in a moment of sort of panic or crisis that haven't been discussed or thought out before, we know there's a risk for worsening outcomes in those scenarios. Those are hard emotionally for everyone involved. And so, what I like to do when I meet people is really talk about, let's have kind of a big overview of this, right? And you tell me how I can help. So, I want to spend just 2 slides talking about um, the feeding tubes and the breathing tubes so that you guys can kind of think about, is this something that you have more questions about for your providers and what this might look like for you? So feeding tubes, often called PEG tubes, although can be called other things depending on how they are placed, they're really recommended for 2 different reasons. The first is to help with nutrition and reduce the risk of aspiration. So we ask people in clinic, how's it going when you're eating? Do you feel like you're taking a long time to eat? Are you having to change either the volumes of food that you're eating or the types of food that you're eating to make sure that it's safe? Are you losing weight, and how much weight are you losing? Because any of those things might be a sign that a feeding tube could be helpful in augmenting your diet. I think it's very important to recognize that having a feeding tube does not stop you from taking oral intake. It just means that we can focus on safe oral intake and maybe supplement using your feeding tube for things like pills, fluids, maybe working with the nutritionist with shakes. But having a feeding tube doesn't mean nothing by mouth, right? And then I care a lot about feeding tubes because we know that your respiratory status can help guide understanding about the safety of placement. So the recommendation is that a feeding tube is placed before that forced vital capacity, that measure of expiratory muscle strength, before that number declines less than 50%. And much of the data suggests that doing so with interventional radiology is the safest route of placement. So I want to kind of walk you through how this is placed so you can understand why your respiratory function is so important in this. When you do this with interventional radiology, this is done under conscious sedation, okay, a moderate sedation. So you are in a bit of a twilight state. But we don't do general anesthesia, and we don't put you on a breathing machine or a life support machine. We do have you use either your BiPAP or your non-invasive ventilation to help you take these bigger, deeper breaths while you're getting this medication that makes you a little bit sleepy. To do the procedure, we need you to recline to about 30 degrees. And so we talked about in the beginning of this how sometimes people might notice that they have more difficulty with certain positions. And so we want to make sure you have that ventilatory reserve that you can tolerate that 30-degree angle. And then to be able to safely put in the feeding tube, we know that we need to inflate your stomach temporarily with air. And when you do that, it pushes up on the diaphragm and it decreases the amount of air you have in your thoracic cavity. So again, we want to make sure that you have enough of that reserve to be able to tolerate that. At our facility, we have people stay in the hospital overnight, just one night, to make sure all is well after placement. And then after about 6 weeks, we transition from a feeding tube, which is the PEG tube, which is depicted over here, to a more low profile port called a Mickey button. Okay, so it's something that's much more flush with the skin um, and really not noticeable. Those might, hopefully that gives you a bit of a guideline to kind of talk to your providers and understand why we often bring this up early in the course so that we can help kind of navigate if this is the right decision for you, if this is ever within your goals, and then to know when and why we would place it. And then the last thing I want to talk about are breathing tubes. And this can be a difficult conversation to have, but one that I really want to give you the knowledge and kind of the power to advocate for yourselves and to be able to answer questions and talk to your providers more about. We know that most people or many people end up pursuing feeding tubes, and breathing tubes are a bit different. The data tells us that in the United States, the incidence of tracheostomy placement is about 10%. And we talk about tracheostomies, which is a permanent tube in the neck. We talk about that when non-invasive modes of ventilation are unable to provide adequate support, knowing that we have a lot of ways to support you non-invasively. But we talk about that if we ever do hit kind of a bump in the road where we're not able to get more support. And then sometimes we talk about it following acute illness with respiratory decline. And that was that conversation about really thinking about this sooner instead of making that kind of crisis-based decision making. Almost universally, having a tracheostomy means being continuously attached to a mechanical ventilator. And so this is continuous support. And so those are things to consider about if that's something that would be within your goals and within your quality of life. And I've kind of outlined some other factors that are very person dependent and can help you make the decision about if this is the right decision for you. One, we know that by the time that we would talk about breathing tube placement with a tracheostomy, we know that voice and an ability to communicate or ability to swallow is likely already impaired. And so sometimes that would not change people's decision. But I always counsel people that if either of those things are still intact, it's very possible that following tracheostomy placement, those things will become impaired and could become lost. And that's something important to consider. We know that people who have tracheostomies have increased risk of infections and therefore can have increased risk of hospitalizations. And that can be important to think about in terms of quality of life. We know that you need 2 trained caregivers at home who can help manage the tracheostomy. They can help manage the ventilator. These can be family members who are trained by the medical system, who we train, right? The companies train, the hospital can train. But these can also be outside providers, nursing. And there is some cost that's related to that we should think about. And then the last two things that I really bring up when I'm helping people navigate this decision is what's hard about this is a tracheostomy doesn't stop disease progression. And so I always really help people kind of decide, what is the line in the sand, right? We all, as human beings, have that different version of what quality of life looks like. And what my job is as a provider is to get in the trenches with you and to understand what is important to you and what you value. So we can figure out how we can support you over time and to say, where is that boundary? Do you have a boundary? So that we know how we can really navigate this support with you. These are my references if anyone is interested in looking at some of the data more, and I'm happy to take questions. I hope that was a helpful conversation.
Thank you, Dr. Warren. That was great. We do have some questions already, so we will start with those. I do want you to know that we won't be able to discuss any very specific scenarios just because everybody is so different. So if you have a question that is very specific to your own situation, please make sure you're reaching out to your medical team to ask and have them address it for you. And if you haven't submitted your question yet, but you have one, go ahead and take some time to submit it now, and we'll get started. So our first question is, do you eventually be unable to tolerate the NIV?
So potentially, there are a couple things to consider with NIV. So sometimes people can have issues tolerating the mask, okay? And that's why it's really important to try to get a good mask fit and talk about things like skin breakdown and ways that we can help protect your face. There are times where we hit a limit in terms of the amount of sort of non-invasive support we can give. And that's that conversation that then talks about, is more advanced support with a tracheostomy something that would be within your goals. There are a lot of things we can do with non-invasive ventilators, and I have had several people over several years, the decade that I've been doing this, use their device with nasal pillows 24 hours a day. And they're going out on boats and going to baseball games and really, having that independence. And so the answer is yes, but I also really encourage you that if you're feeling like you're having not good enough support with your NIV, that you really talk to your care team about ways that you might be able to augment things over time.
Great. Thank you. We have somebody asking if you can just pull up the reference slides again. We can just pull those up and leave them up.
Maybe. There we go. Can you all see that?
Yep, I see them great.
I pulled up the chat. I don't know if I'm blocking anything.
Nope, you're okay. We can see the full slide. Okay, another question. IVAPs and AVAPs appear to be trade names. The V stands for volume. Can you explain how tidal volume is an upgrade over in and out pressure?
Yes. Okay. So that's a great question. And I wondered if I should talk about that in this. So, BiPAP itself is a pressure regulated mode of ventilation where I give you an inspiratory pressure and an expiratory pressure, and you take a volume. So if I give us all 12 centimeters of water, we might all take a half a liter of breath or 300 cc's of breath, but we're not guaranteeing that at all, right? AVAPs and IVAPs, you're right, they are a trademark thing depending on which machine you get. But we can target a volume with varying pressures. So I can say, I want you to get a half a liter of breath every time that you breathe. And so when you're sitting there and maybe awake, more awake and participating more in breathing, maybe you need lower pressures to be able to achieve that volume of air. But as you fall asleep and maybe as those everyone takes more shallow, more infrequent breaths at night. As you fall asleep and as you're participating kind of less in breathing, then that pressure ramps up to where you are assuring that volume. And so it's a bit of a more advanced mode of ventilation. So typically I just start out with true blue BiPAP numbers. But over time, if people are having more symptoms of maybe feeling fatigued during the day, having daytime headaches, etc., um, and we're just sitting there kind of fiddling with those pressures. Sometimes I say, let's just go to a volume assured mode. And that can help with people feeling better supported for sure. That's a great question.
Thank you. Are magnetic clips safe for use with pacemakers?
Great question. It depends. So you should always ask your provider that. So we have had this in clinic where we have specifically looked at the type of pacemaker and the product line, and sometimes the answer is yes, and sometimes the answer is no. And so I very strongly encourage you to talk to your care team about that. Excellent question.
Okay. Another kind of clarifying question regarding the MIP.
Mhm.
Normal is greater than -60. So
Mhm.
in that normal range, are we going more negative, as in like negative 65, or the other direction, like -45?
Yeah. Also great. And we talk about this quite a bit. So -70, -80, all of that is better and better. Okay. So the lower, the closer to zero it gets, the weaker that number is. Okay. And it's the whole number that I'm talking about, not the percent. And so anything higher, 70, 80, etc., above 60, that is stronger.
Perfect. Thank you. Couple questions on BiPAP.
Mhm.
First one, do I let the machine determine the respiratory rate, or am I supposed to determine the respiratory rate, meaning the person wearing it?
Mhm.
And secondly, does overuse of BiPAP accelerate muscle deterioration?
Okay. So the first question about who sets the rate, the answer is both. So what happens is when you get a BiPAP, you should get a BiPAP that's called a BiPAP ST. That's what all people with ALS should be prescribed. And what that means is that it's a spontaneous timed mode machine, meaning that if you are doing it, that is great. You are fully setting the rate. But we have a backup rate. So maybe at night, if your respiratory rate drops and you're breathing 6 times a minute, and I, as the provider, want you to be breathing 10 times a minute, it will then nudge you with that inspiratory pressure and say, hey, it's time to take another breath. And so that's one of those things where if you're using it and you're like, wait, I didn't want a breath, it's giving me a breath. You can talk to your provider about maybe turning down some of those settings, tweaking some of those things. So I hope that answers that question in terms of it's really a both. But if you are doing it, that is great. Okay. It's just really having that kind of guaranteed backup. And then no, more use of the device does not lead to dependence. And we know from the data that there's really survival improvement and quality of life improvement. And this is not something that you become dependent on. Great question.
Perfect. Thank you. Questions about cough assist. Um, can you start it too soon? Is it bad if you start it before you need it? And should you use it if you're not having any issues with cough?
Um, I don't think that you can necessarily do it too soon. I mean, there are certainly when I see people in clinic, if they very clearly are having no issues, if their lung function tests are looking great, I will counsel them on it to say, hey, this is something I have in my toolbox. If you think you need it, if I think you need it, I'll let you know about it. But there's many times we forego doing it until maybe we feel like we need it. Like if I have people mimic a cough in front of me in clinic, I'll say, okay, how are you coughing? And they'll say, I cough fine. I say, show me. And they'll, if I'm like, yes, that's a great cough. If you're not having things like that, frequent throat clearing, et cetera. And so um, the downfall of starting it too early is that there is a copay associated with it. So I don't think that you necessarily have to do it. And I apologize, Amber, I forgot the second half of that question.
No, you answered it. Can
Oh,
do
good.
should you, can you start too early, and should you start it before you need it?
There's no harm, really.
Perfect. Some questions about trachs. Does having a tracheostomy and being on a vent require 24/7 support?
Does tracheostomy require 24/7 support?
Correct.
Yes. You never say never in medicine, right? And so, although there can always be cases that people have heard about, having a tracheostomy means 24/7 support with a ventilator and needing 24/7 support with a caregiver as well. And so, it can be really a shift in terms of quality of life. And so that's one of those things that I really want to make sure that you have the knowledge about what that looks like, um, um, to make sure that this is the right decision for you.
And a follow-up question to that, can tracheostomies be reversed?
Um, in general, and I don't know, I'm going to answer this in two ways in case this question was posed in a specific way. So have I had people who have had a trach very early in their course for something completely unrelated and then went to have that trach removed, saying that they would never want that? Yes, I have had people remove a trach. Um, if you're asking if you get a trach and you're on a mechanical ventilator and you say, this is not something I want anymore, we don't reverse the trach in terms of taking it out, but there are ways to then put boundaries in and say, this is not something that you want anymore, and talk about other ways to maybe transition support. I don't know if that's what you were asking.
I think that was a great answer for that question. Well, we are unfortunately out of time. If we weren't able to answer your question and you would still, you've got a burning desire to have that question answered, please reach out to your care services coordinator or your care navigator with the ALS Association, and you can send them that question and they can pass it on. Or, as I mentioned before, reach out to your medical provider. That is absolutely what they are there for. But thank you so much, Dr. Warren. It was wonderful information, and we've got lots of comments saying thank you and just echoing that sentiment that it was a really great presentation.
Well, good. Thank you so much for having me. I really appreciate it. And I see I see some people I know. And for that Lubbock, Texas comment I saw, I grew up in Dawn, Texas, if you know where that's at. So small town farm person now over here in Nashville.
Huge area too. It's funny to run into people like that. Well, just a couple of reminders. You'll be able to view this recording on our Empowering Your ALS Journey webinar page once it's posted, and that is at als.org/webinars. And you'll also be able to view all of our past webinars and sign up for future ones. I hope you'll be able to join us again at our next Empowering Your ALS Journey webinar, which is titled Exploring ALS Clinical Trials, What They Are, How to Find Them, and What Happens Next, which will be on Monday, March 16th at 2 p.m. Eastern Time. And just a final reminder that there will be a short survey at the end of this webinar, and your feedback is so important to us. We really appreciate it. So thank you again, Dr. Warren. We appreciate you sharing all of your passion and your time and your knowledge with us. And I thank you all for joining us. I hope you have a great rest of the day.
Thank you. Bye.